Dr. Epstein, and thank you all for your time today. It's an honor to be here again at an OCR. I was here 2 years ago, and this year, I think as Dr. Quinn previously, I probably wandered before because I was assigned two major tasks to speak about preventable skin toxicities and what you can do about preventing some skin toxicities that you see in your patients, and how to identify serious complications. So with that, I would like to start listing my disclosures. And as a matter of background, obviously you know that there's 1.6 million people diagnosed every year with cancer in the US, but importantly, even before you start treatment with chemotherapy, radiotherapy, or even surgery as part of the therapy or diagnosis, 45% of these individuals will have skin findings. Most notably, they will have skin infections such as tinea pedis, onychomycosis, very dry skin, probably related to age, pruritus, as well as bacterial infections. The consequences of dermatologic conditions that I will be showing you throughout the presentation are fourfold. They have an effect on a psychosocial impact on patients, of course, because they affect areas of the body exposed to other people. They carry a financial burden, and we have showed that treating dermatologic toxicities leads to significant increases of about $2,000 in cost for patients for the numerous creams and other medications that we prescribe that in many instances are not covered by insurances. And they cause an effect on physical health. And this is one of my long-term goals, and I think that we have advanced a lot, is convincing those outside of dermatology that skin conditions are not only important because people may look ugly, but people that have skin conditions when they are pruritic, they can affect sleep, leading to decreased quality of life. They also, even due to their cosmesis, they can affect quality of life, leading to dose discontinuation or interruption. And also they can cause skin infections, which in some cases can be fatal. But finally, what is considered the most important result of skin conditions is that they can affect the dose intensity of your cancer regimens. And we have demonstrated that by surveying oncologists that EGFR targeted agents in particular lead to a significant impact in terms of dose intensity that I will be showing you later on. But why are we speaking about this? Well, as we have seen today through the great presentations, and all the speakers have very eloquently demonstrated, targeting any of these pathways or proteins involved in malignant behavior, you are able to reverse to a benign phenotype in a variety of solid tumors, leading to the spectacular success of many agents. But I think that it is important to know that if these targets are located in tumors, they are also located in skin, as you can see here. And not only are they located in skin, but they are critical for the normal homeostasis and functioning of normal skin. Keep in mind that the skin is an organ that is constantly renewing itself. Every 28 days, you will have a completely new layer of epidermis. And this, for those of you that may not believe this, you may know that all the dust that you see in your homes is not dust coming from outside, but the skin that you have been shedding as you are in your homes. It is important to remember also that VEGFR inhibition and PDGFR inhibition that has been abundantly talked about today is also important for the normal vasculature in skin, and perhaps the reason as to why VEGFR targeted therapies result in hand-foot syndrome that we will be seeing. And you can see here that targeting either of those pathways or proteins, such as the epidermal growth factor receptor, VEGFR, the BRAF, or as we saw, PD-1, and the mammalian target of rapamycin inhibitors, by any of the agents, irrespective of whether they are small molecules or monoclonal antibodies, will result in a consistent appearance of dermatologic side effects that you can tell what the patient is receiving just by looking at the patient as they walk into your office. So it is important to keep this in mind, because that way you can focus your attention on the toxicities that are most important at the time and not those that may not be occurring with a particular group of agents. And I was also asked to speak about communication with patients and families. The only thing I can say about that is that only about 8% of patients with dermatologic conditions due to cancer therapies end up seeing a dermatologist. Surveys that we have conducted have shown that up to 76% of oncologists report that they have to stop or modify an EGFR inhibitor due to rash alone, and that it is critical to establish a referral system in which you as an oncologist or an oncology healthcare provider can call a dermatologist that can see a patient in a defined period of time, usually within several days, and that's why what I do at our institution, we know that patients usually will not come back to see a dermatologist. And it is important for you as an oncologist, I think, to know that studies have been conducted about dermatology wait times. And the best solution, we know that they are very long. The best solution and suggestion that I can provide you is to tell you that if you become friendly with a dermatologist and can call them directly, they will see patients more rapidly if you need them to see them. And this data is important because it has been borne out by studies that have been done by Jack Resnick at UCSF. And what he did as a dermatologist, he called 900 dermatology offices in the US and called pretending to be a patient and said, I have a changing nevus. And as you may know, for most dermatologists, a changing nevus is the most critical or emergent condition that can occur. It turns out that when Jack called these offices and said that he had a changing nevus, the median wait time was 38 days. And that was exaggerated. A year later, he repeated the same study, this time saying, I want to get Botox. Then the median wait time was only 8 days.
Yeah.
So if you want to get your patients faster into a dermatologist, either tell them that the patient wants Botox or you can become friendly with the doctor. So they also asked me to speak about life-threatening cutaneous adverse events. And fortunately, I don't have a lot to talk about here because these are very rare. And I have to tell you that 9 out of 10 or more of patients that are referred to me for possible hypersensitivities or Stevens-Johnson's TEN are not indeed those conditions. And I'm just giving you some hallmarks here that would indicate to you that that a condition that one of your patients is having could be a life-threatening reaction, keeping in mind that the most common culprit for hypersensitivity reactions and Stevens-Johnson syndrome are likely platinum-based agents as well as the taxane-based agents, Paclitaxel and Docetaxel. So what are the important things to look out for in a type 1 hypersensitivity reaction? As you know, multi-organ systems involvement with sneezing, dyspnea, angioedema, as you can see here. Also, you can see, of course, anaphylaxis, and all of you know how to identify and manage this very well. Then there is another acronym that was given called DRESS for drug rash with eosinophilia and systemic symptoms. I think this is just a very pithy acronym to just label a hypersensitivity reaction, and really does not lead to any more significant toxicity. The other toxicity that is important to keep in mind and how you can identify this is, of course, the feared Stevens-Johnson syndrome and toxic epidermal necrolysis seen here. Remember that this condition is extremely rare. It is characterized by painful desquamation of the skin. There is necrosis of the epidermis that becomes very painful with violaceous blisters that always involve the oral or conjunctival or genital mucosa, as you can see here. And these are two characteristics that are mandatory for this diagnosis. So I think that keeping those in mind will be very helpful to assuage your concerns whenever a patient has a rash. And we have conducted an analysis and analyzed the database for Mouthwash and as well as in PubMed to see what are the most common anti-cancer agents that cause Stevens-Johnson's and TEN or life-threatening adverse events. And the most common culprits are usually agents seen in liquid tumors such as bendamustine and the other agents listed here. If you are interested in this information, I can email it to you. I will be showing my email at the end. But let's move on to the toxicities that can be prevented. Nowhere is this more evident than with the acneiform rash to EGFR inhibitors. You know that very well. I'm sure most of you have seen this numerous times. Importantly, this rash is associated with pruritus and tenderness in about 62% of patients. There is a moderate to severe decrease in quality of life. As you know, about 2/3 of patients are affected, depending on the agent. Keep in mind that Vandetanib, recently approved for medullary thyroid cancer, also causes an acneiform rash, and Pertuzumab, recently approved for breast cancer that inhibits the dimerization of HER2, causes rash, although to a lesser extent, in only about 25% of patients. The rash, importantly, I'm glad that 50% of you responded that you would treat prophylactically. And what I would like to think about dermatologic conditions is the same way you look at other conditions, such as gastrointestinal toxicities. For example, whenever you prescribe highly emetogenic chemotherapies, you give patients antiemetics ipso facto. So hopefully this will also occur with patients that are developing skin toxicities, and you can mitigate these. As you know, this can become infected after it occurs. These secondary infections in patients treated with EGFR inhibitors occur in about a third of these patients. Anytime you see a lesion that is discharging pus, I recommend to obtain a bacterial culture because we have seen a wide variety of bacterial agents infecting the skin of these patients, and it is understandable if the epidermal barrier is disrupted, the microbiota in the skin will take over and secondary infections will ensue. So if you have a patient with an EGFR inhibitor, has a severe rash that is not responding to your antibiotic of choice, consider doing a bacterial culture because almost always you will see either that there is the culprit is a bacteria that is not sensitive to that antibiotic. We all know that the greatest irony of this rash is that a worse rash is correlated with a better survival, and this is the silver lining in all of this and what motivates many patients to stay on therapy despite the severe rash, although after the rash occurs, most patients would like to mitigate it. As I had mentioned before, a survey of more than 110 community oncology practices in the U.S. showed that those oncologists, about a third, have stopped EGFR inhibitors due to rash alone, and about 2/3 have modified EGFR inhibitors because of rash. So certainly we don't know what the implications of decreasing the dose will have on clinical outcome, but I know that it leads to a lot of anxiety in patients not receiving their agent, and understandably it likely lessens the efficacy of these agents. So one of the trials that showed that this rash can be prevented is the skin toxicity evaluation protocol with panitumumab, in which a skin moisturizer applied to the skin, a sunscreen that had broad spectrum protecting against UVA and UVB, a topical steroid, albeit of low potency, I would have used something of higher potency, and doxycycline 100 milligrams twice daily was given to patients prophylactically at the onset of therapy with panitumumab 2 until 6 weeks. And these patients were compared to another arm. These were a total of 95 patients in which patients were treated with best supportive care. The results of this study are shown here. As you can see here in the prophylactic arm, 29% of patients developed grade 2 or worse skin toxicities compared to 62% of patients in the reactive arm, with the odds ratio favoring the prophylactic arm. In other words, there was a greater than 50% reduction in grade 2 or worse skin toxicities when patients were treated prophylactically. Furthermore, grade 3 or worse skin toxicities, as you can see here, were also decreased when treated prophylactically, as highlighted in yellow, both the rash, itching, infected rash or pustular rash, as well as paronychia. Serendipitously, it was also found that patients that had diarrhea and dehydration, this was significantly improved when they were treated with this regimen, suggesting that perhaps the antibiotic doxycycline had an effect on the gut flora, minimizing the diarrhea, which was probably induced by concurrent irinotecan. Another agent that I just wanted to bring to your attention is Emend or aprepitant. You use this widely for the prevention of nausea and vomiting. It turns out that the neurokinin 1 receptor is present in skin cells, and substance P ligation to neurokinin 1 receptor leads to itching or pruritus. As you know, the Emend tripack, how it's administered, and a recent paper in Lancet Oncology showed that patients with pruritus secondary to targeted agents, when they received this is a visual analog scale of the intensity of the pruritus from 0 to 12. You can see here at baseline, it was about 8. When patients receive aprepitant, likely due to its NK1 receptor antagonism, there was a significant reduction in pruritus in all of these patients, as you can see here. And interestingly, the median duration of one cycle of effect was up to 30 days, and more than 50% of patients did not develop a recurrence of the pruritus after 3 months. So keep that in mind when you're prescribing aprepitant and you have patients with pruritus, as several papers now have shown the benefit in mitigating this untoward event. Moving on to a different agent, BRAF inhibitors. We know that BRAF V600E mutations, as well as other mutations, are present in over half of melanomas, but also to a lesser extent in thyroid cancers, non-small cell lung cancers, and colon cancers. And indeed, at the moment, there are numerous studies being done with BRAF inhibitors in all these other tumor types, but of course, Vemurafenib has been approved for the treatment of melanoma because the overactivity of this pathway by the BRAF mutation can be abrogated by the administration of Vemurafenib, which reverts to a benign or controlled phenotype. Dabrafenib is also an agent that is likely to be approved in the next few years. We know that there are common toxicities with vemurafenib, such as maculopapular rash, alopecia, and hand-foot syndrome. I will be showing you the important toxicities that warrant increased attention. The first one is photosensitivity, occurring in 42% of patients, grade 3 and only 3%. These patients are only outside for 10 minutes and they get sunburned. This type of sunburn is important also because this is UVA-induced sunburn, which means that it can go through window glass, car windows, or any type of glass. So if a patient is in the car, they can get sunburned. If they are in their homes, but they have the window open, even though the glass is there, they will get sunburned. And we have seen this, and this was documented by Reinhard Dummer, as you can see here, when he used a sunscreen that protected against UVB, and patients were on vemurafenib, there was no erythema. This photosensitivity, I think, is as severe or even more than that seen with other agents such as Vandetanib and voriconazole, which, as you know, is very severe. So broad-spectrum sunscreen protection every 2 hours or more frequently if swimming or sweating is recommended in these patients, as well as sun-protective clothing. Another important toxicity that has been brought out is the development of these secondary squamous cell carcinomas. This is nothing new. We had reported this in 2005 with Sorafenib in several patients. With vemurafenib, about 21% of patients develop these growths on the skin and usually occur within about 6 months. These growths result from a paradoxical activation of wild-type BRAF in the skin in the presence of HRAS mutations in sun-damaged skin. So keep in mind that histological analysis has been conducted for these lesions, and the good news is that the majority of these lesions are what we call keratoacanthomas, which is one of those names that in dermatology we like to give to very simple things just to make them sound more interesting, which are benign behaving squamous cell carcinomas. In the majority of the time, you can just treat these lesions symptomatically by either removing them, and that should suffice in most cases, especially because we know the responses to vemurafenib are not long lasting. Another toxicity, since we were speaking about prostate cancer earlier today, is nail toxicities with taxanes and what can be done to mitigate them. With Paclitaxel and Docetaxel, you see these nail changes. Prospective evaluation of Docetaxel-treated patients showed that 80% of patients develop nail toxicities. These toxicities are significant because they impair quality of life, and they can become secondarily infected in about a quarter of patients, as you can see here. 2 papers that have been published, one of which was published in JCO, showed that the use of this cold glove during the infusion was able to reduce by 4-fold the incidence of nail toxicities of all grades in patients in the gloved hand compared to the hand that was not gloved. So if you have a patient with significant nail toxicity to taxanes, consider using cold glove therapy. And I know logistically it's very difficult, so at least what we do is we have the patients put their hands in ice packs during the infusion of taxane-based therapy if they want to minimize nail changes. And also, Judy Pace at Northwestern is investigating it for the prevention of neuropathy. Hand-foot syndrome to VEGFR inhibitors, as you know, is a very common symptom occurring in about 60% of patients, grade 3 in about 10 to 20%. I never thought I would see a patient in a wheelchair coming to my office, but patients do come in wheelchairs and they cannot walk because of this painful condition. Only one study has shown any benefit for this, published or presented at ASCO last year. Sorafenib-treated patients for HCC were randomized into either urea or moisturizers, and what was found was that urea 10%, in other words, this is available OTC, Eucerin with 10% urea, was able to reduce by almost 20% the severity of hand-foot syndrome. There are other interventions that may be effective for this that I am just not presenting today because they are not based on randomized data, but that I think are very effective, such as high-potency topical steroids in those very painful areas, and also the use of topical anesthetics such as lidocaine. And one trick that I've learned over the years in treating so many of these patients is there is the lidoderm patch that what I have patients, when they have very painful areas on the soles of the feet, they cut the lidoderm patch to wherever it hurts and they stick it there all day long and they are able to walk without pain. Hand-foot syndrome to cytotoxic agents is a little bit different, as you know, because as opposed to previously where you saw those painful blisters, this is more of a diffuse redness on the hands, as you can see here. more commonly with fluorouracil, capecitabine, and doxorubicin. Importantly, vitamin B6 pyridoxine has been demonstrated to be not effective. And the only study that has shown any positivity is patients treated with capecitabine randomized to Celecoxib or controls, showing that prophylactic Celecoxib was able to reduce grade 2 or worse HFS by more than 50%, from 72% in the control arm to 29% in the Celecoxib treated arm. Finally, I would like to conclude with radiation-induced toxicities because I think these are probably one of the most undertreated and mistreated types of toxicities that I see. You know that these are very severe, especially in head and neck, breast, and GU cancer patients. We know that there is an increased risk of radiation dermatitis and mucositis when you add cytotoxic agents or targeted agents. I just wanted to show you this briefly just to tell you that biafine doesn't work. The only topical agents that have shown to be positive for the prevention of radiation dermatitis are topical corticosteroids of high potency used at the day of initiation of radiation. Here is a list of all these studies that have been positive, and a good review is listed here. For oral mucositis from radiation, there is one study that showed positivity for oral fluconazole, 34 patients treated with fluconazole, of which only 14% had grade 3 or worse mucositis, compared to almost 3 times that amount in the placebo arm, suggesting that Candida does indeed play a role in the symptomatic mucositis of these patients. Another study that was positive, although very small study, was using a cocktail mixture that had hydrocortisone in it, and in fact, this is what we use. I like to think of mucositis as dermatitis inside the mouth. What do we do for dermatitis? We use topical steroids. So this study used topical steroids, and what was found was that there was a clinical and subjective improvement by more than 50% in the treated patients compared to the placebo-treated patients. And these figures illustrate that. In the clinical evaluation, the control group was much higher than the experimental group. Finally, we've talked about mTOR inhibitors abundantly today for the treatment of renal cell carcinoma. Mucositis from mTOR inhibitors is very different from other types of mucositis. Mucositis from mTOR inhibitors looks like after stomatitis, as you can see here, and this is very painful. And we have learned from the transplant literature that clobetasol, topical steroids applied inside the mouth in these sores, are effective in reducing the duration of this oral mucositis. We know that the incidence of mucositis with temsirolimus is very high, about 60% of patients, so anything that can be done to mitigate this would be welcome. If you're more interested in references for this, I'll be happy to provide them to you. But I think I need to conclude with speaking about magic mouthwash, because magic mouthwash is something that is used widely at every institution. And what is interesting about magic mouthwash, as you can see here, is that every institution will have a different permutation of what is in magic mouthwash. Probably it varies by what pharmacist is at work that day or what day of the week it is. And importantly, it is used so widely that I became interested in it about 7 years ago when I saw so many patients on it. So I looked through the literature, and I found that the only paper that has been published testing magic mouthwash is the one listed here, published in a dental journal. This is a paper done in the UK in 2000. And what this paper showed, as you can see here, is that patients with chemotherapy-induced mucositis were randomized into either magic mouthwash, soda water, or chlorhexidine wash. Patients were followed, and what was found was that magic mouthwash was no better than salt soda or chlorhexidine. So the conclusion from the investigators was that since salt soda is the least expensive of these agents, this is what they would recommend to these patients. And what this study taught me is that the magic in magic mouthwash is that it doesn't do anything. So I would like to conclude with the following conclusions. Dermatologists have an important role in oncology. Early and proactive approach towards toxicities is advisable, and the characterization of these conditions will increase in importance as these drugs enter the adjuvant setting and you use combination therapies. Thank you very much for your time.